the orthoPAC, hosted by Sam Dyer. Welcome to the orthoPAC, where we discuss up-to-date orthopedic topics for the busy clinician. I invite you to sit back and relax as I attempt to fill in the gaps between education, current events, and real-world practice.
Hello, everybody, and welcome back to the orthoPAC podcast. My name's Chuck Dowell, guest hosting this episode today. I work primarily in orthopedic urgent care, so I see a lot of acute injuries. I think this is a common injury that we see in a lot of patients across all of the fields of orthopedics and or family practice, urgent care medicine, ER medicine. So I had a 48-year-old gentleman comes to clinic complaining of acute pain within his calf area. He states he was trying pickleball for the first time. Now, we all know that pickleball is one of the fastest growing sports throughout the country and throughout the world. So I'm sure as many of you do see a lot of pickleball injuries. This gentleman said he was pushing off on his right leg, felt a pop within the right calf / Achilles tendon area, was unable to continue to play, subsequently went to the urgent care, was diagnosed with concerns between a calf and or gastroc strain or possible Achilles tendon injury, and was placed on crutches and in a posterior splint and asked to follow up with us in the orthopedic urgent care. I thought this was applicable because there was an interesting presentation recently at the Orthopedic Foot and Ankle Society annual meeting in September of this year, where they did a study looking at pickleball injuries between 2015 and 2023, and they found that pickleball injuries had increased 6.5-fold over that time period. During that time, they saw 198 injuries. The mean age of the patient was approximately 58 years old, and 70% of those injuries involved the calf, 78 Achilles tendon ruptures, and the rest were either gastroc or soleus injuries. So again, with pickleball being one of the fastest growing sports in the world and throughout the United States, and us seeing a lot more of these injuries coming in, I think this is a common thing that we're all going to see in our clinic. So for this gentleman on examination, he had quite a bit of edema diffusely throughout his calf area, primarily within the medial head of the gastroc, but also extended through the middle and lateral head of the gastroc. The edema extended into the posterior Achilles tendon area. He did have palpable tenderness right at that musculotendinous junction on the medial head of the gastroc. No palpable defect can be felt within the area, but some firmness in the area was felt, likely consistent with a hematoma. His Achilles was intact distally to palpation. On examination of his Achilles, this is another thing I think to discuss, because oftentimes when we see these injuries in clinic, somebody comes in and says, I have acute pain within the back of the leg. They feel like somebody kicked them in the back of the leg. All of us have a high suspicion of Achilles tendon ruptures. Achilles tendons are probably one of the more common injuries to this area, documented as being more common than gastroc strains as well. And there is some literature that shows that these can be missed in up to 25% of the patients. So I think when I'm evaluating anybody with a posterior gastroc, posterior calf type pain, acute onset, I always have them lie down in a prone position so I can see both calves from behind. I can look to see if there's any significant edema within both areas, any palpable defects within both areas. I try to have their feet hanging off the edge of the table, and I think what that shows me is the resting position of their foot. Oftentimes with people that especially having a full Achilles tendon rupture, that side with the injury will be in slightly more dorsiflexion than the side without the injury, because the Achilles tendon will naturally pull us into a little bit of plantar flexion. So in that resting position, you'll see that that foot is slightly more dorsiflexed than the opposite side. I think, again, you can palpate the Achilles tendon much more comfortably in this prone position. So I'll usually start by palpating the distal aspect of the Achilles tendon and then working my way up. Most of the time, you can palpate that traditional deformity within the Achilles tendon that occurs approximately 2 to 6 centimeters above the insertional area. That's often quite obvious, but sometimes there could be some palpable tenderness, and or this could be up more proximally 6 to 8 or 10 centimeters above this insertional area at this musculotendinous junction at that Achilles, where the soleus and the gastroc meet to form that Achilles tendon. This patient had complete Achilles tendon was completely intact. He had no palpable defects within the area. Again, most of his tenderness was up along this mid calf and or upper calf area at the musculotendinous junction of the gastroc, and mostly the medial head of the gastroc. Again, literature does show that medial head tends to be injured more often than the lateral head. there is some literature that shows that there is a bit of a watershed or poor vascular supply to this musculotendinous junction at this medial head of the gastroc and or at the musculotendinous junction of the gastroc itself. I think one of the bigger things to consider is this a gastroc injury or a soleus injury? So if we remember, the gastroc does bypass two joints, so it goes past the ankle and goes past the knee as well, where the soleus only goes past the ankle. So oftentimes the mechanism of injury, I think, is important with this. Most of the time, if it's a gastroc injury, the knee will be in a fully extended position and they'll have that forced dorsiflexion or eccentric force against the posterior calf area. Since the gastroc goes beyond the knee joint, this often puts the pressure onto that gastroc tendon and typically causes the injury there. Sometimes these gastroc injuries will actually be up higher within the popliteal fossa or even the insertional point on the posterior aspect of the femoral condyles. The soleus typically has a similar injury, forced full dorsiflexion and eccentric force, but typically this is with the knee in flexion because, again, the soleus doesn't cross the knee joint. When the knee is in flexion, this isolates the soleus more, and these injuries can be more consistent. If you're trying to distinguish on physical exam between a gastroc and a soleus injury, oftentimes the soleus won't have as much palpable tenderness superficially. They'll feel like it's deep tenderness. You can palpate around that gastroc area and they'll say, yeah, that hurts, but I feel like the pain is deeper to that. And oftentimes they'll form a hematoma and or some type of fluid collection between that gastroc and soleus tissue plane. And typically that causes that deeper pain, which often causes that intercompartment pressure. And again, typically that is what results in the pain. So again, for this patient, he did have that palpable tenderness within that medial gastroc area. He did have that fullness within the area as well. Some early ecchymosis was noted as well. So if we remember, we try to grade these. It's pretty universal on how the grading system works. Typically a grade 1 involves a stretch and or strain to the gastroc and or soleus area, but no palpable defects can be felt. Grade 2, typically there is more of a partial tearing. You can feel some palpable defects or hematoma collections within the area. They may have more significant swelling diffusely throughout the calf and into the distal Achilles area. And then grade 3 will be a complete tear, typically at that musculotendinous junction. They'll be unable to weight bear, and you usually will have a palpable defect on that side. This patient presented more as a grade 1 to grade 2 strain. Again, no palpable defect, but did have significant diffuse edema. One of the things I think to address as well is the incidence of DVT with these patients that come in with these acute gastroc and or posterior calf injuries. The incidence of DVT has been reported to be somewhere between the 5 to 20 percentile range for people with medial gastrocnemius tears. They think this is multifaceted. One, secondary to the localized swelling and the inability to weight bear on the affected leg often causes this. The swelling can also cause some compression on the intermuscular veins and from the local hematoma, which could cause a raise in compartment pressures and possibly cause the DVT to form. I do often send these patients for ultrasounds to rule out DVT, especially early on, and or if they are continuing to have diffuse swelling 7, 10, 14 days post-injury, I'll send them for another ultrasound to rule out DVT. It's not a terrible idea to put these patients on to a full-strength aspirin, 325 milligrams, as a possible prophylaxis to DVT as well. But again, I think something definitely to keep into consideration, especially for these patients. So again, returning to our patient in question, he did have, as I said, a grade 1, grade 2 gastroc injury. He seemed to be more around this musculotendinous junction. We discussed with the patient regarding treatment. I think the initial treatment often is sufficient to be in a boot. Typically, I'll put a heel lift in the boot to put some plantar flexion into that foot to reduce the stress across that Achilles tendon and our gastroc area, as that full dorsiflex position seems to be more painful for the patient. If they can't weight bear in the boot without significant pain, I'll typically have them use crutches. Oftentimes, this is 5 to 7, sometimes 10 days use of crutches. Again, anecdotally, just me and my particular practice, I'll typically tell them if they have a 3 out of 10 or less pain on a personal pain scale, I'll allow them to weight bear with the boot. If it's more than a 3 out of 10, I recommend they continue to use the crutches. We'll follow the normal principles with most of these: elevation, ice, anti-inflammatories as necessary. When to start physical therapy is a bit controversial. Some literature does show start therapy right away to try to reduce any large hematoma collection within the area. Some of the literature shows to hold off for 5, 7, maybe 10 days to allow the acute pain to settle down and then start physical therapy activities. Normally, conservative treatment can be used for all of these gastroc tears as well as soleus tears, again, because it's very hard for us to surgically fixate these. The degree of the tear significantly reflects how long it will take for these to typically improve. Most of these grade 1 tears can take 4 to 6, but also up to 8 weeks for a complete resolution of symptoms. Grade 2 can take 8 to 12 weeks, and grade 3 can take up to 4 to 6 months to completely resolve. So again, typically crutches for 7 to 10 days, ice, anti-inflammatories, using the walking boot with the heel lift in place. They can start physical therapy at some point during that time to try to start some passive active assistive range of motion, start some eccentric loading activities to try to improve the healing of the gastroc tear. One of the things I warn all the patients about, and what I've seen anecdotally, is that a lot of patients start to feel better around week 2, week 3, and this is the point where they start to come out of the boot and try to return to sports activities. I think this is the most precautious time that the patients need to know, as this is the time when they start to feel good enough where they can start to go back to sporting activities such as light pickleball activities. Maybe they'll say, hey, I usually play singles but want to play double activity and or doubles. I think this is the time when the muscle is most prone to re-injury, right around that 3 to 4 week period, because a lot of the edema has settled down, a lot of the early muscle has started to form and started to heal within the area. And oftentimes these people will go back to play these sporting activities, re-injure that, and they'll be right back at square one 6 to 8 weeks before they can participate back in sports again. So I warn all the patients around week 3, week 4, they'll feel good enough to try to do these activities. I always recommend that they wait 1 week past feeling good before they try to return to any sports related activities. Whether or not to get an MRI, most of the time we won't get an MRI on these patients if the diagnosis seems to be more consistent with a gastroc and or soleus tear. It's up in the more proximal calf area. If we do think that the injury is more at this distal calf / gastroc soleus musculotendinous junction with the Achilles tendon, then we will get an MRI to rule out these kind of high Achilles tendon injuries that can be fixated surgically and oftentimes do need to be fixated surgically. So depending on where the pain is at and the patient's presentations, an MRI can still be useful. If we don't get an MRI initially, the patient is 3 to 4 weeks into treatment and not getting significantly better, it's not out of practice to get an MRI at that point just to make sure there's nothing we're missing. There are definitely different structures within the area that can be injured. A differential diagnosis can include plantaris injury, soleus injury, intramuscular hematoma, and again, Achilles tendon injury. So this patient actually went on to do quite well, did a boot for 3 to 4 weeks, limited and protective weight bearing, progressed back into all sporting activities by 6 to 8 weeks, had no re-injury, and did quite well. So again, I think this is an interesting case that we all see throughout all aspects of medicine, especially with pickleball being an up-and-coming sport. This recent presentation showing that 70% of pickleball injuries are these lower extremity calf Achilles tendon injuries. I hope you enjoyed this case presentation, and we'll see you at the next episode. Thank you.
Thanks for listening to our podcast today. I invite you back next week when we have our 200th episode for PA Week, and we visit with some leaders of our profession discussing where we've been and where we're going. Also be on the lookout for our last quarter membership drive for new members and an effort to bring in some active military members as well. You're going to want to look for this, as there will be some nice giveaways to promote it, starting with PA Week. So stay tuned to the podcast for announcements and follow our social media channels and read the e-blasts that come to you that give you more details.